Thank you very much. Thank you for having me here, everybody at this Swedish conference. It's really cool to have this happening here in Sweden. I've been doing lots of traveling, doing lots of different psychedelic conferences and medical conferences around the place, and everybody is always really enthusiastic and fresh and full of ideas and loads of conflict and debate, which is cool, exactly how it should be. So this is a very bold thing to suggest, the future of medicine, but really what my work in both child and adolescent psychiatry, addiction psychiatry, and psychedelics, and particularly MDMA, has really shown me that these psychedelic medicines, and in my particular personal preference, MDMA, really could be the new paradigm for psychiatry, a whole new way of looking at pharmacology, which moves away from this medical model of treating symptoms towards a cure. Now, the cure word is not a word we use in psychiatry. We've got too used to becoming just learned helplessness, the way we treat our patients. We behave as psychiatrists as if we're palliative care doctors. We patch people together and we stay alongside them for the whole of their psychiatric career. But there's a sense that we can never actually cure them, get them out the door, because they're always going to be ill. Now that's a very desperate situation, and of course it's not like that for all people, but significant number of cases in psychiatry become chronic. And if you're going to see your psychiatrist in your 20s with a severe anxiety-based disorder such as OCD or addictions, there's a pretty good chance you're still going to be seeing your psychiatrist in your 60s or 70s after a lifetime of maintenance therapy medications. Now that's not good enough. We need to be doing better than that. So for me, 20 years in medicine, I think that the psychedelics offer us the best, most innovative new way forward of all the pharmacy that I've come across and the psychotherapies. So it's a really real passion for me in that way. And when I look at my own career, it's mirrored that of my patients. So after training in medicine and then specializing in psychiatry and then child and adolescent psychiatry, working with abused and maltreated children for 10 or 15 years, watching the development of complex PTSD in adolescents and seeing that develop into adult disorders, into addictions and lifelong anxiety type disorders based around trauma. My own career has followed that as well. So I'm now working in adult addictions as well as working with young people as well. And all of this has come to the door of MDMA, and hopefully I'm going to explain to you why I've come to that. So there's a picture, and it says, there is a stronger link between childhood trauma and addiction than there is between obesity and diabetes. 2/3 of addicts report being abused as children. That means the war on drugs is a war on traumatized people that just need help. Now, when we look at that picture of that little girl, we see a scared, bruised, humiliated, excluded, frightened, neglected little girl. But what do we see when she's 40 or 50? And she's scum. She's public enemy number one. She's sitting out on the street and she's asking you for some money. She's HIV positive. She's hepatitis C positive. She's an intravenous heroin user. She's alcoholic. Suddenly, all of our compassion and all of our understanding has gone. And we have all this sentimental empathy for these little abused children. And we see them on TV and these poor little victims of child abuse, and our hearts open to them. What happens to those little ones when they grow up? They start wearing a hoodie, and they start smoking weed, and then they start using amphetamine and cocaine, and by the time they're in their 20s, they're using heroin and alcohol. And suddenly, we've just turned off our empathy switch, and we just see this scum, this person who wants our money. Now, that's absolutely outrageous. It's wrong. And it's wrong for two reasons. Firstly, it's obviously morally and ethically wrong to not be compassionate towards all people, however they got to where they are. But secondly, when we fail to recognize this developmental trajectory from child abuse into adult mental disorders, and particularly addictions, we're missing out on the science of this issue. We're failing to recognize the obvious, inevitable developmental trajectory that happens if you hurt and humiliate and bruise and exclude a child. They inevitably grow up into this damaged adult. So what I want to be thinking about today is not only the compassion and empathy for this subject, but also the importance of us as intelligent people, perhaps clinicians, recognizing this developmental trajectory, because it's outrageous when I come across other professionals, even mental health professionals, who have these stigmatizing negative views towards adult mental health patients, personality disorders, people with addictions, and they fail to recognize this. So we know about the different sorts of child abuse, and we understand the biggies, the ones that social services come into contact with: sexual abuse, physical abuse. But what I always say is, don't take your eye off the ball when it comes to the emotional abuse and neglect. I've worked with many people who have had very severe personality difficulties and addictions, and we've searched their records for what we think must be obvious high signs of severe physical or sexual abuse, and it's not there. What we have, though, is this emotional abuse, and it's often that drip, drip, drip effect. I didn't love you. I never loved you. Your dad didn't love you either. We didn't want a girl. We wanted a boy. You're unlovable. No one's ever going to love you. Even if people say they do love you, they don't really mean it. That kind of emotional abuse that undermines a child's development is absolutely crucial. Because what it all comes down to, and child psychiatrists always bang on about two things. One, they talk about attachment, and secondly, they talk about boundaries. These are very important, the cornerstones of child psychiatry. Now, attachment is the most wonderful thing to watch as a clinician when you're working with children and families. It's this beautiful pre-verbal experience in the first 18 to sort of 25 months of life, in which the child and the primary caregiver, normally the mother, bond. And they bond through a shared mimicry of behavior. They mimic one another. It's quite fascinating to watch. And it creates the blueprint for our adult psyches that we carry into the rest of life. And it sounds rather fatalistic, but really it's those first 5 years in which you form the core fundamental parts of your personality, the core issues. What is love? What is trust? What's the point in telling the truth? Why shouldn't we lie? What are friends? What are parents? What is aggression? What is violence? These really crucial things you learn very, very early in life. And when you mess with that, you can have quite profound changes that become very rigid. So it's not just psychological issues like attachment. Also, any of you who work in mental health will know that there's multiple social factors. We work with the people on the bottom rung of the ladder in psychiatry. We work with the people in the lower socioeconomic statuses. And most of the people with chronic mental health problems have multiple risk factors. So they have the poor genes. They have the genes for depression, anxiety, addiction, personality disorders. They come from the poor neighborhoods. They have poor education. They have unemployment. They have lack of hope. They have poor parenting styles. They have parenting criminality. They have parenting drug and alcohol misuse. So it's a multiple stacking of negative factors. Because if you've got any positive factors in any of those areas, they can outweigh the others. So you could have a poor complement of genes, but have excellent parenting and really good education, and that can protect you, and vice versa. If we were going to practice eugenics, which obviously we can't, we would get all the nice posh kids from the posh part of town with the good schools and the great parents, and force them to mate with all the people from the poor part of town to mix the genes up a bit. We don't do that. But the point being is that it is this multiple factors. All of those poor genes hang around in the poor areas. They're not evenly spread across the society. So a bit of a physiology lesson. Now this area here in red is the amygdala. I'm just going to get some water. The amygdala is a very old part of the mammalian brain that fires in response to stress. If something frightening happens now, someone comes running into the room with a knife, your amygdala will fire. It'll say, you're in danger, get out. It's a bottom-up process. It's not under the influence of higher centers in the brain. It's a very instinctive survival technique, and it triggers a hormonal response called a fight, flight, or freeze response, which readies you for action. And you don't need to think about it. Your brain will just do that for you. Now this area in the green is the prefrontal cortex, a much more sophisticated part of the brain. This is the part of the brain where we use judgment and values and logic and reasoning, and we can overcome this amygdala response with the prefrontal response. So these two areas are in communication with one another. So your amygdala response is, you're in danger, you've got to get out. And then a few nanoseconds later, your prefrontal cortex will kick in. Well, I don't know, it's okay, I reckon I can talk to this guy, we can reason this, we can work something out, I don't need to run away. So if you're a little child that's been brought up in an environment where from 1 minute to the next, you don't know when your caregiver comes into the room, are they going to give you a kiss and a cuddle, sit down on the floor with you and play a game, or are they going to punch you, or are they going to kick you, are they going to burn you with a cigarette, or are they going to rape you? And when you grow up in that environment, you grow up and you develop an inflated amygdala response. You actually have physical brain changes that result in the amygdala becoming hyper-reactive. You find things more frightening than other people. You're constantly on edge. Now, this is in some ways a positive response. This is a neuroadaptive response. If that kid didn't develop this heightened amygdala response, they're going to die, because nobody's looking after them. It's absolutely right that they learn that when their caregiver comes into the room, they run and hide, because they're going to get kicked and punched if they don't. So you get these physical brain changes. You also get a shrunken prefrontal response. Your prefrontal lobe does not develop. It becomes attenuated and shrunken. So you're not very good at seeing the good in things and talking yourself round and being positive. It's not an advantage to do so. If you try and see the good in this violent, aggressive caregiver, you're just going to get hurt. So you grow into this physical brain state. Now, the result of this is you build up in childhood very rigid patterns of thinking, very rigid, and using this attachment model and this hyper amygdala model, you develop narratives about yourself and the world. So myself, I am useless, I am a failure, it's my fault. This is the thing about abusing children. It's an extraordinary design fault in the human brain. Sometimes I look at my patients and I think, if only you'd had the adult logical brain when you were being abused. If you hurt and abuse a child, they don't say, no, stop, you shouldn't be doing this, you're supposed to be my carer, you're supposed to be looking after me. They say, sorry, it's my fault, I must have done something wrong, I've done this. So you grow up with these narratives. I am useless, I am a failure, I am a slut, I deserve to be raped, that's what I am. And you grow up with these negative world narratives. The world is dangerous, people are not to be trusted. Get the boot in first, otherwise you're going to be in danger. And the result of this is, it's so hard to overcome this, and it's so hard to be with those thoughts about oneself, that the only option is to block them out with sedating substances. Because none of us want pain, and I work with my addict patients, and I sometimes say to them, look, I can't blame you for wanting to use heroin or alcohol. You don't want pain, I don't want pain. All of us work in a way to take pain away, and it's understandable that you're going to do this, and it's very hard to move on. Now, it's difficult to treat trauma. Trauma underlies so many of these mental illnesses. It's so hard to treat, and there's no single treatment. What we do is we treat symptomatically. If they're depressed, give them an antidepressant. If they can't sleep, give them a hypnotic. If their mood goes up and down, give them a mood stabilizer. If their hypervigilance, this jumpiness, goes over the edge and becomes paranoid, give them an antipsychotic. None of these medicines are actually treating the cause. They're just treating the overlying symptoms as they arrive, and you have to keep taking them every single day, day in, day out, in order to avoid the symptoms. Similarly, many sorts of psychotherapies, EMDR, DBT, trauma-focused psychotherapy, CBT, CAT, IPT, you name it, lots of T's. And psychologists in the room may disagree with me, but in my experience, 20 years in psychiatry, what I think underpins all good psychotherapy is the essential, let's talk about your pain. It really is where we start and where we go in psychotherapy. Let's talk about these issues. Now, that's fine for about 50% of people with severe PTSD. They talk about the pain. They cry, they slowly learn to overcome that fear response through working with the therapist. But for a significant half of people, the minute you talk about the pain, they're out the door and they're back to their bottle of vodka. Because just the word rape is enough to make them drop out of treatment. They can't even begin to think about the idea of thinking about their pain. By the time they're in their 40s or 50s, they've spent their whole life doing anything but thinking about that night when they were 8 years old. They've developed an entire structured defense mechanism around not going there. It may involve heroin, it may involve alcohol, it may involve self-harm, suicide attempts. But they will not talk about that thing. And the psychotherapist sits down with them and says, tell me about your rape. They can't do it. So we have a high treatment resistance. 50% become the chronic disorder. And high rates of alcohol and other drug misuse. And high rates of completed suicide. This is not good enough in modern psychiatry, okay? We've had 100 years of modern psychiatry, and we're still treating these disorders symptomatically, and 50% of people are unnecessarily becoming chronic sufferers. So I would say we are in psychiatry today where we were in general medicine about 100 years ago. Now, 100 years ago, we were losing the battle to the infectious diseases. We knew that people died after operations. We knew that people got some kind of infection that killed them with a fever. We were very good at epidemiology at the end of the 19th century. We wrote long statistical manuals about smallpox and cholera and tuberculosis, but we didn't know what was going on. And then we learned about the microorganisms, and then we got the antibiotics, and we finally started to begin winning this battle against the infectious diseases. Now, I would propose we're in the same place in modern psychiatry. We know all about depression and anxiety in terms of its epidemiology. We write these huge, voluminous mental disorders diagnostic manuals, and we categorize people into different diagnoses. But our treatments are poor. Our treatments are lousy because we're not tackling the cause, the core infection. We give these drugs that paper over the cracks and treat the overlying symptom. I think an analogy I would use would be, if you have an infection, one of the symptoms of an infection is a temperature, a fever. Now, you can take paracetamol or ibuprofen to bring your temperature down. Why not? It's a good thing to do. You'll feel a bit better if you bring your temperature down. But those drugs are not antibiotics. They're not going to kill the bug. When we give people long-term SSRIs for anxiety-based disorders, affective disorders, addictions, personality disorders, we're just treating the temperature with a paracetamol. We're not getting to the bug. If only we had an antibiotic. I think you can see where this is going. So 3,4-methylenedioxymethamphetamine is a quite remarkable molecule. It sits here amongst the phenethylamines. We can roughly differentiate psychedelics into these two groups based on their structure. And in terms of their effects, it sits here in this group with the 2C series and others like MDA, but MDMA is by far the most well-known of that group of drugs. So it's not a classical psychedelic. It's an entactogen. If you were going to invent a drug for trauma-focused psychotherapy, it would be MDMA. That's what you'd come up with. It ticks all the right boxes. It's short-acting, it's mildly classical psychedelic, but not sort of dripping walls and ego dissolution, but enough to make you think outside the box and be creative. It's extremely safe in therapeutic applications. When I used to do these talks about MDMA, I would spend hours talking about ecstasy and all these tables and graphs demonstrating the safety. I just don't bother now. That question is well answered by the psychopharmacology community. MDMA is a remarkably safe compound, especially in the clinical setting. I'm happy to answer some questions about safety if people want to ask them, but I just skip over that now. It's almost always pleasurable. Now, that's a very important factor. There's not that many drugs in psychiatry that are like that are invariably pleasurable with most people pretty much all the time. Another group would be the opiates. I challenge anyone in the audience to take heroin and not love it. If you don't like heroin, you don't have a brain. These things are hardwired into our nervous system. And that positive felt mood that you get with MDMA is very important clinically. It makes it a very easily tolerated drug, as I'll show from some of the data from our study. But what it really does, it's this aspect of enhancing empathy through allowing access to painful traumatic memories. And if we look at the receptor profile, we've got effects at the 5-HT1A and 1B. This is the positive felt mood, the lowering of depression and anxiety, the kind of warm euphoria part. Very important for patients like I described who've only ever felt fear. From the day they were born, they've only ever felt fear because they've got this exaggerated amygdala response. 5-HT, so this is where the classics like LSD and psilocybin act, but in a much more gentle way. Then you've got this paradoxical effect. You've got the amphetamine part of the molecule results in this dopamine and noradrenaline stimulation, which engages the patient into doing the work. It's very good as a motivator. But you've also got this paradoxical relaxation at the same time. And if any of you have ever taken MDMA, you might be used to that experience of being both speeded up and slowed down at the same time. This is very important, this relaxation, because it takes the edge off this hypervigilance effect. And these two together result putting you into the optimal arousal zone. You're speeded up enough to take part, but you're slowed down enough to not be overwhelmed by the hypervigilance. So it's this perfect zone for psychotherapy. And then, of course, there's a hormonal response at the hypothalamus and a release of oxytocin. Now, oxytocin is a hormone that's released from the brains of breastfeeding mothers. It's a hormone that engenders a sense of engagement and attachment and bonding. So when you throw all these effects in together, and from a amygdala point of view, there's our traumatized brain. What we've shown from studies at Imperial is that MDMA does the exact opposite. It shrinks the amygdala response. People on MDMA do not find things so frightening. You can put them into experiences that normally they would find scary, and on MDMA, they are able to cope with that. And we've demonstrated this with fMRI scanning. And it boosts the prefrontal response. It boosts this ability to see the good in things, to see the good in yourself, to recognize positive attachments where they are. And it's interesting with PTSD, I always ask my patients to look outside of the window in the clinic where I work in Weston, and I'll say, you know, tell me about those people down there on the street. And they'll say, you know, he looks really dodgy, she looks really dodgy, there's no way I'd trust him, she's gonna just screw me over, you know. And I say it's really weird, because I look out the window and I think, he looks really nice, I'm sure she'd be my friend, I bet he'd help me if I needed some help. So we don't live in reality, we all live in our own little version of reality based on what we've experienced, particularly as very young children. And this is well demonstrated. People with PTSD see scowls and anger in a crowd of faces that other people don't. It's quite extraordinary. We don't live in a single reality. And if you've grown up your whole life with this kind of impairment, it's hugely disabling in terms of psychosocial relationships. So we add together all of those effects of the receptor effects of MDMA, and this is really what it does. This sums it up better than anything else. It selectively inhibits the fear response, whilst leaving the other faculties intact. Now that's really important. Many drugs will inhibit the fear response. A bottle of vodka will inhibit the fear response. A bag of heroin will inhibit the fear response. And that's why our patients use these very powerful drugs. Why not? They don't want to live in fear. But they're messy drugs. They're messy. You can't remember what you've done after a bottle of vodka or a bag of heroin. What's so great about working with MDMA is the rest of the sensorium is clear. The patient can walk and talk, remember, they can reflect, they can think about their past memories, they can debate. And I often ask the patients the next morning, were you just talking a load of rubbish yesterday? Were you just high? Was that just gobbledygook? And they say, no, absolutely, I stand by every word of it. I know exactly what I was talking about. I just wasn't scared. And I've had these symptoms, whether it's PTSD or addictions, for 30, 40, 50 years. And yesterday, for the first time in my life, I spoke for 6 hours non-stop about what happened to me when I was 8 years old. I've never been able to do that, and I remember it all. It's quite extraordinary the way that works. So, just wanted to mention a bit about this dangerous legal high. Alcohol is a huge problem, especially in Britain, and you can see this amongst the British delegates here at this conference. We have a very unhealthy relationship with alcohol. It's endemic, and it's culturally sanctioned, and it's killing people. Over a quarter of people drink harmfully in the UK. Massive amounts of dependence, huge financial burden. So when we had the opportunity to develop a study with MDMA, I chose alcoholism because it's such a massive clinical, personal, financial burden, and the treatments are very poor. So the very best that current modern medicine can offer with alcohol addiction, this is after post-detox, you have a medical detox, you have all the best that we can throw at you, individual therapy, group therapy, mutual aid partnership groups like Alcoholics Anonymous, all of this rehab, inpatient settings, the very best thing we can throw at you, the outcome is around 80 to 90% of people will be drinking again within 4 years. Now that is crap. That is rubbish. We were doing better at treating alcoholism in the Victorian times than we are today. We absolutely need something. So when we started this project, we thought, will this work? Will alcohol respond to MDMA? There's a lot of work with addictions with classic psychedelics. In fact, most of the major work done in the 60s with LSD in the 1950s and early 60s was with alcoholism. So it's the classic psychedelics since then have gone on to have some more contemporary studies. We heard from Matt Johnson yesterday about his nicotine study. Michael Bogenschutz has done an alcohol study with psilocybin, and we've had studies with ketamine looking at alcohol and opiate disorders. And what we've found with all of these classic psychedelic treatments for alcoholism, what they've all found is the strongest therapeutic effect happens when the patient has a mind-blowing peak experience, a spiritual, mystical experience. And the greater the depth of that mystical experience, the greater sobriety and staying off the substance that they had. Now, this was an immediate problem for us. MDMA doesn't classically produce a strong mystical spiritual experience. Data suggests that it occurs in about 10 to 15% of first-time high-threshold dose users of MDMA. They'll talk about cosmic oneness and connecting with God and these mystical spiritual experiences, only 10 to 15%. And it's more like 80 to 90% with the classic psychedelics. So we thought, well, that bit's missing. But what we did know was there was this very strong effect on trauma and empathy. And so we looked at the work of Michael Mithofer and the work that's been done by MAPS with PTSD, and we looked at the high rates of trauma that underpin addictions, as I've described, and we put 2 and 2 together, and we've come up with 5. Is it possible that Mdma-assisted psychotherapy could work in a population of addicts? And it's never been done before. So this is the world's first ever MDMA addiction study. And it's the first clinical study with MDMA in the UK as well. So that was our team years ago now. It's taken us a very long time. We're doing an open label study, so there's no control group, there's no placebo. Now that's absolutely fine, and that's the first study you have to do when you're doing a brand new study in a new population group. So they all get MDMA. They get 2 doses of MDMA, 125, and then a booster dose 2 hours later, and that occurs on two occasions. So there's 2 sessions, and they stay overnight, and that's our team there. David Nutt, you might recognize. He's a world-famous dude. And we're looking, obviously, at alcohol abstinence and drinking behavior, but also a whole host of other mental health issues, quality of life issues, sleep measures, those kinds of things. So that's what the structure of the treatment looks like. They start with a medical detox. Now, they start with a screening before their detox. They come in and they have to pass typical rigid inclusion and exclusion criteria, which are pretty typical for most psychopharmacology studies these days. I can explain those in more detail if anyone's interested. They then get their alcohol detox. So this is 7 to 10 days with a high-dose benzo like chlordiazepam epoxide. And when they're then dry, they come out of that and they start their 8-week course of psychotherapy, which is over 10 sessions over 8 weeks. 2 of the sessions are Mdma-assisted, where they stay in overnight, and the others are all outpatient psychotherapy. And we then follow them up at 3, 6, and 9 months. So that's the Mdma study, the Bristol Imperial Alcoholism Study. And because it's a safety and tolerability study, more so than a treatment study, the main outcome measures are really, are they tolerating this? Is it safe? David Nutt said to me the other day, we were talking about the outcome measures for the drinking. He said, look, don't worry about the drinking. This is a safety and tolerability study. If you can give 20 people MDMA, 20 alcoholics, if the government doesn't shut you down and nobody dies, you've done a good job. He said, if a couple of them don't drink as much, that's a bonus, but we're really not looking at that. So that basically sums up what an open-label pilot safety tolerability study is. Those are the main outcomes. We are, of course, interested in drinking behavior, and it's looking very good. So myself and Laurie have trained in Mdma Therapy through the MAPS model, and we look at a whole load of physiological stuff throughout the sessions. They have their heart rate and blood pressure and temperature measured every half hour for the first 2 hours, and then hourly. They stay in overnight. They're monitored by night sitters. Chloe is here. She's one of our night sitters. And a lot of these safety measures are imposed by the ethics board or the MHRA, and they are, in our opinion, a bit too risk averse, but you've got to play the game and do it that way, because that's what they want. So 15 minutes. Cool, cool.
For questions. So,
I'll try and finish a bit early, so if anyone has any questions. Yeah. So, yeah, MDMA, incredibly safe. And the important thing about clinical MDMA is this is not ecstasy. It's nothing to do with ecstasy. It couldn't be further from ecstasy if it tried, really. Imagine a rave where before you go to the rave, you go along and you give a blood test and you have an ECG, and then when you go to the rave, you've got a doctor on one side and a psychologist on the other, and they take your temperature every half hour, and then you stay overnight at the rave, and they see you in the morning, and then they phone you every day for a week afterwards to ask how you are, then they see you every week for another 3 months, then they follow you up at 3, 6, and 9 months, they do another blood test, another ECG. Not a very fun rave. So this is not clinical ecstasy. This is not ecstasy, and we must not make inferences about harms that we see in the ecstasy-using population and make inferences about clinical MDMA. So just a few shots of what's going on. There's our medicine in Bristol. There's us planning the sessions. There's our team. These are some of the qualitative. So we've got 7 people, 6 people fully enrolled at the moment, 2 women and 4 men. 4 people have had their 2 sessions with MDMA. Some of the qualitative responses there, really quite interesting. People talking about, it's quite surprised me in a way, it's almost behaving like a classic psychedelic. People are talking about this peak experience. We thought we would be focusing on index trauma events, but instead what we've got is people saying, this has blown my mind, I can see the world in a new light. And always a very positive, heart-opening type of response. I can start living again. This one guy broke into song, I can see clearly now. So it really is looking good, and the numbers are very small, but the important thing is that it's being well tolerated and people are finding it useful. There's a very, I mean, that's such a stupid graph because it doesn't say anything other than everything's going fine. No abnormal physiological responses, no adverse events, no MDMA affect drop in the week after the session. Really important that we did that with these telephone calls. I want to write a paper called Blowing Away the Myth of Black Monday. You know, this ravers anecdote, Black Monday, Blue Tuesday, people go to these rave parties and then they feel rubbish at work on a Monday or Tuesday and they say, oh man, it's serotonin depletion, it's a hangover. And so we've been measuring that, no suicide risk, everyone's very positive, and crucially, nobody is drinking. These were all heavy, hard, daily dependent drinkers with physical dependence who've been drinking for 20, 30, 40 years. None of them are drinking. So we've got planned a randomized control study, which is going to be roughly the same thing, but we're going to randomize into 2 groups and have a placebo and a MDMA group. And then we'll give the placebo group a single MDMA open label session at the end, just so everyone knows they're going to get some MDMA at some point. And we've added an additional pair of therapists to the team, and we're just looking for funding. So if anyone's got £804,000, come and meet me afterwards. How much? 804. No? 800 will do. So just a minute or two just to briefly talk about this Psychedelic Renaissance. That's a fantastic book. We're in an area now with this research where we've eclipsed the 60s. Yeah, people talk about the psychedelic 60s. This is the psychedelic era now. We've eclipsed that. We really are. We're pushing all over the world with this. It's been a great pleasure for me to be involved in all of these different groups. In the last 10 years, I've, on various occasions, received and given LSD, DMT, psilocybin, MDMA, ketamine, as a healthy subject. We're really pushing back the frontiers here with this cutting-edge neuroscience, and there's been some great people working on it. And that's Michael Mithofer, and he's a pioneer of the MDMA psychotherapy for PTSD. And this is an important question. I get a lot of young people that come to me and they say, Dr. Sessa, I'm really interested in doing this, but I talked to my tutor about it, and they said, you're crazy, this is madness, why do you want to do that? This is career suicide. And this is what people said to me. I remember 15 years ago when I was in Oxford, my tutor said, why are you aligning yourself with these crazy hippies? Why don't you study something nice and wholesome like SSRIs? It's career suicide. This will ruin you. Well, it hasn't ruined me at all. Quite the contrary. It's, you know, it's a growing career that is now at the cutting edge. So if you have your tutors, any of you young people that are interested in this, and you get that sort of negative vibe, you have to just say to them, read your journals, yeah? This is not just some crazy fringe subject. This is cutting-edge neuroscience. All of the world's major neuroscientific institutions are now running psychedelic programs. We recognize that these are the tools for future psychopharmacology. They're the tools for us understanding the nature of consciousness, and they are the new paradigm for drug-assisted psychotherapy. And we need to do this research. We owe it to this population of patients, and we owe it to this little girl. Thank you.